Hello, and welcome to today's webinar, Supporting Title V and Medicaid Collaboration in Pediatric Medical Home Implementation. My name is Joanne Jones. I'm a pediatrician at Asian Health Services in Oakland, California, and a member of the National Center for Medical Home Implementation Project Advisory Committee. This webinar is co-sponsored by the National Center for Medical Home Implementation, the National Academy for State Health Policy, or NASHP, and the Catalyst Center, the National Center on Health Insurance Coverage and Financing of Care for Children and Youth with Special Health Care Needs at Boston University. The goal of the National Center for Medical Home Implementation is to ensure all children and youth, particularly those with special health care needs, have access to a medical home. NASHP is an independent academy of state health policymakers dedicated to helping states achieve excellence in health policy and practice. A nonprofit and nonpartisan organization, NASHP provides a forum for constructive work across branches and agencies of state government on critical health issues. The goals of the Catalyst Center are to promote universal, continuous, and affordable coverage for all children and youth with special health care needs, close benefit and financing gaps, promote payment for additional services, and build sustainable capacity to promote financing of care. Before our faculty begin, I'd like to inform you of some housekeeping items. The slide will appear in the central window of your screen and will advance automatically. We encourage you to ask questions throughout the presentation using the question box window on the left-hand side of the screen. These questions will be answered at the end of the presentation. If we do not have time to answer your questions during the webinar, we will send you an answer directly via email at a later time. This webinar will be recorded and archived on the National Center for Medical Home Implementation website approximately 1 week after this presentation. After the webinar, you will also receive an email with a link to the webinar evaluation. We encourage you to complete this evaluation so that we can continue to improve the content and manner of our presentations in the future. Today's presenters have no financial or conflict of interest disclosures to announce. Please take a moment to review the 3 learning objectives for today's webinar. The National Center for Medical Home Implementation is a cooperative agreement between the Maternal Child Health Bureau and the American Academy of Pediatrics. Through the partnerships with NASHP and the Catalyst Center, the National Center can provide timely, practical policy resources and technical assistance to Title V programs, Medicaid agencies, pediatric clinicians, family advocacy groups, among other pediatric medical home stakeholders. This webinar is a result of these partnerships and comes at a time when the majority of state Title V programs have selected National Performance Measure 11, medical homes. Official collaboration and partnership between Title V programs and Medicaid agencies is required through block grant guidelines and will support improvements in National Performance Measure 11. It is now my pleasure to introduce our first speaker, Karen Van Landeghem. Karen is a Senior Program Director for Child and Family Health at NASHP. Karen.
Thanks so much, Joanne, and thank you to the American Academy of Pediatrics for their partnership through this work for the National Center for Medical Home Initiative and other projects that we work on with AAP, and to our partners at the Maternal and Child Health Bureau and the Catalyst Center. My presentation today is going to be brief, but it's really designed to do some stage setting from a national perspective As you heard from Joanne, NASHB's work is of, by, and for state health policymakers. So that is the perspective I bring to today's presentation. I'm going to start with some of the major trends we're seeing at the national level with regard to important considerations for improving systems of care for kids with special health care needs through a medical home, and some considerations for partnerships between state Title V children and youth with special health care needs programs and Medicaid agencies, but also other stakeholders like pediatric providers, families, consumers, and others. I'm going to briefly highlight a few states and then leave you with some questions and food for thought, and then turn it over to the Colorado folks for their presentation. Just to say a little bit about why I want to begin with some trends, I think talking about the trends that are happening at the national level with regard to kids with special health care needs is really important because it's where we at NASHB, and I know other of our partners, are seeing a lot of the collaboration and partnering happening between Title V kids with special health care needs programs and Medicaid and others like pediatric providers and families. And it's also where we see the greatest opportunities. So I'm going to talk a little bit about some of the major trends. One of the biggest ones we're seeing, and this is hot off the presses and yet to be released, work that we're doing at NASHB in the area of Medicaid managed care for kids with special health care needs, but that we're seeing nearly all state Medicaid agencies, 47 to be exact, plus the District of Columbia, contract with managed care organizations for services, and they enroll at least some children and youth with special health care needs, either mandatorily or voluntarily. And so this is significant because clearly Medicaid managed care provides an important opportunity for states to partner on what that actually looks like and how those systems are structured to best serve the kids with special health care needs and their families. This is a huge, rather significant jump from just back in 2010 when there were only just 32 states reporting that they serve children with special health care needs in Medicaid managed care. And we know from work that the Bureau funded in the early 2000s that that was even less back then. A second major trend, and I'm sure this is no surprise to many of you, is just a big focus on integrated care. Integrated care through a medical home for both adults and children. I recognize that the AAP really, the idea of a medical home comes out of the AAP and was really for children and kids with special health care needs, but now is being really used across the country, as we know, for adults and children. And this notion of integrated care is significant. And where we see the biggest changes happening are especially with regard to integrating care between behavioral health and primary care. Next slide, please. We're also seeing new models of care and service delivery systems be developed in states, and that's really across the country, as state Medicaid agencies in particular and working with their partners are really trying to focus on improving quality of care, improving outcomes, health outcomes, and then reducing healthcare costs. And we're seeing also that there are some pediatric ACOs popping up across the country. So again, another important trend and also another important opportunity for partnering and collaboration. We're also seeing a lot of work in the area and attention, both nationally and at the state level, on value-based payment models. There's been a lot published on things like episodes of care, for things like maternity care, excuse me, and also what's being done with regard to care coordination. I know the Catalyst Center has done some work in this area, and Meg will likely talk about that at the end of this presentation or this webinar. But again, a major trend and really something that a lot of folks have their eyes on and a lot of states are actively engaged in working on. It's largely from what we see at NASHB focused on adults, but we are seeing things happen for children, especially for kids with medical complexity. And I think the questions about what those systems look like and what does value-based payment mean when it comes to children and youth with special health care needs is still an ongoing question. Okay, next slide, please. So at NASHB, we have been tracking states' implementation of medical home, and this slide here is from December 2016, so it's a few months old, but gives you a sense of how many states are actually actively undergoing Medicaid payments to medical homes. And this is, I should note, just for adults and children, not just for children, but again, is an important trend and an important opportunity. Next slide, please. And this slide is a similar slide, but also captures what's underway with regard to health homes and really reflects, again, nationally, states' investment in health homes, largely driven by Section 2703 of the Affordable Care Act, which gives enhanced Medicaid payments to states for states that establish health homes. And this, again, is for adults and children, but is, again, an important opportunity. And it's been really a catalyst, both medical home focus and the health homes, in terms of how states are really focusing on kids with special health care needs in medical home, and again, another opportunity for collaboration between Title V and Medicaid. Next slide, please. So I just want to highlight a few selected strategies for advancing medical homes for children and youth with special health care needs, again, that we see nationally and at NASHB, and I know my colleagues from Colorado are going to talk about what they're doing in Colorado, and so you'll hear some more of this. But certainly one big area, and I would say, again, this is not just for state Title V kids with special health care needs programs and Medicaid, but other stakeholders as well. But one of the big things we're seeing, and no surprise, is that there's a lot of interagency collaboration going on. Between Title V and Medicaid in particular, there's actually a federal statutory requirement that there are interagency agreements between Title V programs and Medicaid. It's largely focused on coverage of EPSDT services and the role in terms of EPSDT. But again, it's an important opportunity, a place where we see a lot of collaboration, and also an opportunity for others to be involved. Equally is that as part of that, but also separately, is that there's a lot of partnering going on with regard to representation on advisory committees or councils. You'll hear more of that later on in this webinar. We're also seeing in terms of strategies themselves where states are providing enhanced payments for medical homes. I'm going to talk a little bit about two states' efforts, and Colorado will touch on this as well. Next slide, please. Big strategies and big efforts going along in terms of supporting practice transformation, funds for infrastructure development, technical assistance and trainings for practices and providers, and a lot of emphasis being placed on monitoring and reporting on performance and outcomes. And then finally, and I mentioned this as part of the trends, but we're seeing a lot of states and a lot of partnering between Title V and Medicaid and other stakeholders with regard to Medicaid managed care. So just circling back to kind of the first slide I talked about, but clearly when we have nearly all the states in the country having some populations of children and youth with special health care needs enrolled in Medicaid managed care, it provides a significant opportunity to partner between Title V and Medicaid and others to really help shape for instance, what those managed care contracts look like and what they're including. We know many states, for instance, have used the national standards for children and youth with special health care needs, which was just recently updated. They're using that as a guide to help really think about what those managed care contracts should look like, and so that's a very important opportunity. And then also through Medicaid managed care, and this circles back to the value-based payment, is looking at innovative payment arrangements. Next slide, please. I'm just going to briefly touch on two states, and they may be even represented on this call today and can obviously speak much more to this than I can. Both Connecticut and Texas are good examples, and there's many others of good partnerships between Title V and Medicaid with regard to kids with special health care needs in medical home. I will say that both Connecticut and Texas are, along with other states, are featured in profiles that are on the National Center for Medical Home and Implementation website. So you can get more information about these and other states on the NCMHI website, and information about that will be at the end of the webinar. In terms of Connecticut, and you can read this on the slide, but that's a very much a patient-centered medical home program that was begun in 2012. They have several implementation strategies with regard to the PCMH program, including enhanced payments for certain primary care codes for practices that meet NCQA PCMH level 2 or 3. performance payments for measures including developmental screenings, emergency department and utilization, but several that focus on children with special health care needs. And then a glide path program that provides enhanced match rates to help with startup transformation costs for practices that are trying to get PCMH level 2 or 3 recognition. Next slide, please. The Title V program in Connecticut has partnered with Medicaid in several areas, and it includes work to advise Medicaid on the implementation of that program and making sure that those efforts are connected with the Title V investments for kids with special health care needs in the state. And another big area, and also a trend I might add, is, but certainly in Connecticut, is looking at care coordination for children and youth with special health care needs. So they're working closely with their Medicaid colleagues to make sure that care coordination that is happening out of the Title V program is well coordinated with the PCMH program. And as of June 2015, 97 practices were participating, supporting over 276,000 Medicaid beneficiaries. Again, more information is on the NCMHI website. Next slide, please. Another state that's getting a lot of attention and has been featured in a lot of folks as we talk about states shifting children and youth with special health care needs into Medicaid managed care is Texas. The Texas Star Kids program was just launched in November 2016 and is an effort to now serve children who receive SSI, Medicaid, and children enrolled in the state's medically dependent children program within Medicaid managed care. Again, this state is also featured in the profile on the NCMHI website, but just briefly, Texas Star Kids is really designed to integrate care with the goal of promoting higher quality of care, improved outcomes, and lower health costs, so really the triple aim. There are several specific requirements and standards that are integrated into the Texas Star Kids program and as part of their Medicaid managed care contracts that include things like identification and assessment of kids with special health care needs, standards around care coordination, standards on provider network requirements, and also access to medical homes. And I will say that the Texas program used the national standards for children and youth with special health care needs when they were essentially building this program and rolling it out, and that served as a tool for the states. And I know that state Title V program worked closely with state Medicaid agency in talking about and trying to design what those Medicaid managed care contracts look like. So the next slide, please. And here's just to summarize that the Title V Kids with Special Health Care Needs program is partnering with Medicaid in several areas. They serve on a legislative mandated advisory committee to Star Kids. They've been advising on best practices in serving children and youth with special health care needs and families. As I mentioned previously, they did advise on system standards for the MCOs, and they built that off of the national standards for kids with special health care needs. And then also another big area, and also a trend we're seeing, but a big area for Texas, is that the state Title V program has been partnering with Medicaid to develop quality metrics for kids with special health care needs in Medicaid managed care. Next slide, please. So I just want to leave you with some questions in terms of both relevance for partnering between Title V programs and Medicaid, the topic of our webinar today, but also in terms of strengthening systems of care for kids with special health care needs as part of a medical home. And I think these are some things for food for thought. I know many states are undergoing a lot of this already. But one of the things that I encourage everyone to be really looking closely at, if you haven't already, is to really look at how your state is structuring healthcare delivery systems to meet the unique needs of kids with special healthcare needs and their families. Again, most states are serving children with special healthcare needs within Medicaid managed care, but understanding and knowing which populations of kids with special health care needs are enrolled in Medicaid managed care, is it mandatory or voluntary, and what do those systems really look like, it's really important because it not only it will help you identify opportunities for partnering if you're not already. One of the things that we look at closely when we do work is just trying to understand who's at the table in the development of these models, and certainly Medicaid and Title V children with special health care needs programs are important, but also health plans play a critical role, families of kids with special health care needs, and other sectors like education and mental health, and then also chapters of the American Academy of Pediatrics. Next slide, please. One thing to ask and to look at is really how Medicaid and Title V are partnering and aligning their efforts to advance care for kids with special health care needs. How is your state ensuring access to care and coordinating care? One of the trends I didn't mention early on, but we see, and I know the Catalyst Center has done work and others have as well, is just the focus, tremendous focus across the country for adults and kids on care coordination. And it's clearly a huge opportunity in terms of partnering and also strengthening systems of care. And so care coordination and ensuring access to care is a big focus and also something to be looking into. And then finally, it's just to be really understanding what quality improvement strategies and measures is your state using to promote and monitor quality of care for children and youth with special health care needs. You heard about the performance measure that's being focused on, and also as part of the Title V national performance measures, but also within Medicaid, there are several measures that states are and can be using to really measure impact and quality improvement. So it's another important aspect of really understanding the healthcare delivery landscape in states. Next slide, please. So I'm now going to turn this back to Joanne, and I will just kind of end quickly with a commercial for some of the NASHB work that we have coming out. I mentioned that we did this 50-state review on states' use of Medicaid managed care for kids with special health care needs. That work will come out in September, and for states and those others that are interested, you'll be able to tell across the country which populations of children and youth with special health care needs are enrolled in Medicaid managed care, how states are defining those populations, and get a 50-state review of that. We also will be releasing an issue brief on states' use of Medicaid quality metrics for kids with special health care needs. And so that's another thing that you may want to look at and look for. Again, that will come out in September, but again, trying to shed some light on the opportunities for collaboration and partnering both between Title V and Medicaid, but also key stakeholders like pediatric providers and families and consumers. So thank you so much for your time, and with that, I'll turn this back to Joanne.
Thank you, Karen. Now it's my pleasure to introduce our next speakers, Gina Robinson and Susan Matthew. Gina and Susan work for the Colorado Department of Healthcare Policy and Financing, which administers Medicaid and CHIP. Gina is the Program Administrator for Clinical Services, and Susan is a manager of the Accountable Care Collaborative. Gina and Susan.
Hi, thank you very much for having us. This is Susan, and I'm going to start, and then about halfway through, we will pitch it over to Gina. And I'll do my best to remember to say next slide, please. So first of all, I'd like to just give you a quick overview of Colorado's Medicaid program. We do cover 1.3 million Coloradans, which is approximately 20% of the population of the state. Our caseload in 2015-2016 was at 42% children and adolescents, and then 7% of the population were people with disabilities. That 42% children and adolescents has changed. Prior to Medicaid expansion, we were closer to about 60%, I believe. We had a very successful ACA, Affordable Care Act expansion, so we have seen a shift in that percentage. Of our total enrolled population, approximately 20% live in rural areas, and 79% live in cities with populations above 10,000. 16% of our enrolled population lives in the city and county of Denver. All right, next slide, please. So the department has established with our governor's office as well as with our own internal strategy team several long-range goals that we think tie nicely and support care for our entire population as well as, of course, for children with special health care needs. really to improve the health for low-income and vulnerable Coloradans, to enhance the quality of life and community experience of individuals and families. And we have had a very strong initiative over the past several years of really bringing in that patient-centered care component. And as our pediatric provider friends and others who are working with the pediatric population always remind us that person-centered also includes that family, especially for children with special health care needs. And then finally, to reduce the cost of health care in the state of Colorado. Next slide, please. Colorado has at least a decade's worth of experience with medical homes here in this state. In 2007, we did pass legislation mandating medical homes for children, and that really kicked off a lot of the work that we've done more recently with our Accountable Care Collaborative, which was developed in 2011. Briefly about the ACC, we did develop that really in after 2007 through the first part of 2011, following an unsuccessful attempt at capitated managed care in Colorado. So a lot of the other states do use a capitated managed care program for their enrollees. We have a capitated managed care system currently for our behavioral health care, but our predominant physical healthcare delivery system is not capitated, and I'll talk about the ACC in just a second. The other reason that we developed this kind of hybrid unique program in addition to that unsuccessful attempt was at the time, 85% of our population was in an unmanaged fee-for-service system. So given the need to really help meet some of those long-range goals that I spoke of just a few slides ago, as well as a realization and full knowledge that capitated managed care was just not a system that was going to work for us, we came up with this ACC model. We started enrolling people in May of 2011 with about 500 enrollees, and then in 2012 we really reached full implementation. Next slide, please. So this is just kind of a graphic describing or visualizing the way that we think about the program. There are three really primary components. That care coordination, which is served by the regional care collaborative organizations, a patient-centered medical home, and then it is supported with a data and analytics platform. So we do have 7 RICOs across the state, and then we have some 500 patient-centered medical homes who have a contract with the RICO as well as a contract with us. And then the data and analytics that we provide includes raw claims data to those regional care collaborative organizations, as well as some analytics and information that we track on and that we use to pay incentive payments. And really, the patient-centered medical home, I think we learned a lot with that first implementation in 2007 with the children's medical home. And so we built off a lot of the platform that we've created there. Next slide, please. So the ACC, I mentioned it just briefly. We do have 7 RICOs. The state is divided into 7 different regions, and each region is served by one of the RICOs. We have a couple of different types of vendors currently. We have some more traditional managed care organizations. Rocky Mountain Health Plans is one. And then we have several community, kind of more organically developed organizations. The RICO's role is to coordinate primary care and other services to improve the overall health of their members. They also provide a lot of practice transformation and support, and I think have partnered with several different organizations that also provide a lot of practice transformation for pediatric practices. So I think we have given them the flexibility to develop a model that's going to work for the population that they have. And they certainly have availed themselves of some of the other resources that we have in the state, particularly related to that pediatric population and the special work that some of our partner organizations are doing for children, all children, as well as children with special health care needs. Next slide, please. So the ACC was really developed to evolve over time. And so we started off, as I said, with just those few enrollees, and we have expanded it to include approximately 80% of our total enrolled population. And really, as it relates to those populations of special healthcare needs, children and adults, again, I mentioned that the RICOs receive some claim information on all of their members. That claims information allows them to see what services they've accessed and do some analysis. And we also, one of the ways in which we've evolved on the data piece is we have started providing to the RICOs admit, discharge, and transfer data from the hospital. So they're able to get that more timely. One of the things that we heard and that we continue to hear is that with the claims lag, sometimes that data is just a little bit too late to be actionable. One of the things I remind people is before we had even the claims data, albeit it was a little late, we really had nothing. So I think we've made some important strides, but there's always more that we can do. So we have taken some steps to get more information out to the RICOs and to the providers to help them perhaps develop some strategies that may be more immediate. The program also provides care coordination for the entire health of the individual, as well as some of those social determinant pieces. So we've seen a lot of partnerships with housing and food assistance programs. We've really pushed the RICOs to develop greater partnerships with some of our long-term services and supports organizations. And really, we started with that really foundational medical home piece and then have brought in other partners as everyone's kind of ability to handle more of those relationships has evolved as well. A couple of ways, specifically, I think that we've made some big jumps. We've had some iterative evolution, but back in September of 2014, we did begin to enroll those who were eligible for Medicare and Medicaid as part of our demonstration that we received from the CMMI at CMS. And we required a couple of additional activities of the RICOs as well as our PCMPs. So we developed a very comprehensive service coordination plan that each of those members was to have developed for them, and it required partnerships across multiple agencies as well as, again, some of those long-term services and support providers. We also built in a fair amount of work around disability competent care and trying to really develop some information for practices that were interested in and able to and really wanted to push themselves to become much more accessible for individuals with disabilities. That's been a big lift because it's a big lift on a lot of these practices, but I think they're committed to the work. It just is it's time-consuming work. We also have developed a few different kind of pilots or programs within the ACC. So in 6 counties on the western slope, the western part of the state, we have implemented ACC Rocky Mountain Health Plans Prime. And they are working with some different payment models. We pay more of a capitated model to them, and then they've developed partnerships with their community mental health centers and some of their providers to see about getting greater integration on the behavioral health, physical health care level. We also are now including several child-specific measures for our performance payments. When we started this program in 2011, it had to be budget neutral to the legislature in the short term. So we enrolled primarily adults because most of their savings are achieved in a shorter term. And then we began, as we expanded enrollment, that's when we really began to enroll children as a greater percentage of the enrolled population. As the distribution of the enrolled population changed, we then changed some of our pay-for-performance metrics, and we now have 2 that are pretty child-specific. We have a well-child check rate that they have to meet the 60% or the 80% criteria in order to receive additional payment. That is right now, we're looking at the age group of 3 to 9. We have had that also for the entire pediatric population. And we have also added a postpartum care metric, which obviously we believe has a strong impact on the child's well-being as well. And then we do track on a lot of other measures as well, but they are not being paid out. Next slide, please. So we are in the midst just embarking upon a big transition. We started the ACC as it is now back in 2011, and then full implementation in 2012. We have recently released a request for proposals for new vendors. Those proposals are actually due at the end of this month, where we really are pushing and making some pretty big changes. So ACC Phase 2, the RFP is on the street right now, and we are looking to implement that July 1st of 2018. And we have made a couple of pretty significant changes which we feel will really enhance the care of our entire population, and in particular people who are maybe multi-system involved. So we have two primary goals: to improve the health and life outcomes for members, and again, to use those state resources wisely. Some of the changes that we've made, I did mention earlier that we have a capitated behavioral health program that is statewide. And then we have the ACC, which is also statewide. So for Phase 2, we will have one single regional administrative entity for physical healthcare and behavioral health services. We're also seeking to strengthen the coordination of services by advancing the health neighborhood beyond this important component of behavioral health and physical health integration. A greater focus on population health management. And then we are increasing and making some changes to payment to really pay for that integrated care and enhanced value. And then finally, one of the concepts is greater accountability and transparency. We have been releasing kind of how everybody does on the key performance indicators, and we do release some data in the current system. I don't think that we have used our lever of transparency as well as we could have. All right, next slide. Looks like I'm going over. So I'm going to pitch it to Gina for a few slides, and then once again, thank you very much for having us.
Thanks, Susan. So this is Gina Robinson. I just wanted to give you a really quick overview of what Title V looks like in Colorado. They have an estimated 209,000 children, 0 to 17. Which is about 17.1% of the population. When we started Medical Homes for Children back in 2007, the children's special health care needs population was about 19%. So I'm not sure why we're going backwards, but it is going down. Right now in HCP care coordination, they have about a little over 1,000 members, and the average length of time that they stay in that care coordination is 226 days. Next slide. We do have some really exciting projects in between Title V and the accountable care or the regional accountable care organizations that Susan talked about. In RICOs 2, 3, and 5, which encompasses most of our metro region, they have a pilot program going with our Tri-County Public Health Agency, and that is specific for care coordination for children and youth with special health care needs. As Susan talked about, we also have that Rocky Mountain Health Plan Prime, which coordinates care and services for children and youth with special health care needs with the other local agencies. Again, we are really trying to allow them to develop programs that work in their areas, taking into account rural versus urban, and in Colorado we have Frontier as well. It's also very important that all of the state agencies meet. We talk about our common goals. We talk about what the metrics may be. We talk about what we are going to concentrate on every year, and we're able to be more nimble with the fact that we do meet monthly rather than quarterly or yearly. Our EPSDT outreach portion in Colorado is called Healthy Communities, and they also bridge the communication and care coordination within the Accountable Care Collaborative, and they also manage right now those few clients who are not in the Accountable Care Collaborative, and they're really focused on the life cycle of the member to make sure that the children are getting in for care, that their eligibility stays in place, that if they're going to lose their eligibility, what are the other programs that they could be eligible for. Next slide. So we also have had a great collaboration across the years with our local chapter of the AAP. We always have pediatric representation at our payment reform meetings. at our ACC Stakeholder Advisory Committee meetings. As a matter of fact, one chapter member, Dr. David Keller, and the head of our one of our legal advocates co-chair a meeting for Susan and her group. So we really try to bring everybody in and make sure that we have a strong, visible partnership. The AAP also has been a very strong advocate in helping Colorado towards our adoption of Bright Futures. We work together to make sure that the information is out there, that we remind everybody that the new versions are out there, and the AAP does that for us. Next slide. They're also a very strong partner in training on the EPSCT, the Early and Periodic Screening, Diagnostic and Treatment Program. So we have developed trainings about the program, what it can do, what it cannot do. So we always partner with the AAP on that. And they're always at the table when we're looking at quality, data, analytics, any special projects. They sit at the table with our HCPF medical director and our chief nursing officer. We really try not to do anything that might have an effect on our pediatric community with not having the help and buy-in of the AAP. Next slide. I know Meg is going to talk next, and I really want to just reiterate, Colorado depends a lot on the Catalyst Center. Because I work for the medical director, I always get asked, what do other states do? Just the tools between NASHP and the Catalyst Center are invaluable, and they also provide direct assistance to us as we have questions about moving forward with the Accountable Care Collaborative, or what are other states doing, or what are other populations doing. It's great to be able to have them as a resource. And that moves us into Meg. Thanks for listening to us.
Thank you, Gina and Susan. Now it's my pleasure to introduce our third speaker, Meg Kamo. Meg is a Senior Project Director with the Center for Advancing Health Policy and Practice at Boston University School for Public Health. Meg also serves as a co-principal investigator for the Catalyst Center. Meg?
Thank you, Joanne, and thank you, Gina, for those very kind words. The check is in the mail. It's a real pleasure to be with you all today, and I'm especially delighted to be able to have the opportunity to present with our partners, the National Center for Medical Home Implementation and NASHP. I'm going to spend the next few minutes sharing some resources that the team at the Catalyst Center has developed to help Title V programs in partnering with Medicaid and CHIP in their state. Oftentimes, Title V staff are encouraged to be at the table and develop collaborative partnerships with these two public payer organizations, but that can be difficult to do if you don't know where the table is or what everyone else at the table is talking about. So these resources were designed to help give Title V and other non-payer stakeholders a grounding in the basics of how these critically important public benefit programs work, including vocabulary, rules, regulations, data, hot topics, what's new in the field, and points of focus for partnership activities. Next slide, please. The first resource I'd like to share with you is our Medicaid and CHIP tutorial. This was created in partnership with NASHP, and we thank them very much for that. And designed specifically for Title V staff and family leaders. Each chapter covers an important aspect of Medicaid and CHIP and includes a short, self-scored quiz called Test Your Knowledge, as well as a series of questions to help guide you in finding information, rules, and policies that are specific to your state's Medicaid and CHIP program. Resources for finding the answers to these state-specific questions are included in the tutorial, but the Catalyst Center staff is also available to help you directly if you have questions or want other information. Next slide, please. The individual tutorial chapters include the following topics. How do different systems define and think about children with special health care needs? What are the basics of Medicaid and CHIP? Building partnerships, what kinds of partnerships between Title V and Medicaid are required and feasible to build? this chapter touches on the requirement that Title V programs and Medicaid have interagency agreements, which Karen touched on earlier. The value of Medicaid CHIP and Title V partnerships. Next slide, please. Pathways to coverage, which includes an additional in-depth look at the Tefra-Katie Beckett option for children with disabilities, expanding Medicaid eligibility to this specific population of kids. Covered services, what will Medicaid and CHIP pay for, which includes an in-depth look at EPSDT, the Early Periodic Screening, Diagnostic, and Treatment Program, which is the basic child health benefit program in Medicaid. Financing, how do Medicaid and CHIP dollars flow? Service delivery models, how do states deliver healthcare services to children enrolled in Medicaid and CHIP? Quality measurement and improvement, and a next steps section, making the case for successful partnerships in your state. Next slide, please. These resources are shorter and more targeted than those found in the tutorial and can be helpful in a variety of ways. We've heard from Title V program staff bringing them to meetings with other stakeholders, including them in agenda or briefing books, helping to orient new staff or students, adapting the material for use in their own presentations and funding applications, and more. I want to highlight one of these at-a-glance resources, the customizable interactive worksheets. We've been working for some time on providing materials to Title V on Medicaid and CHIP, but more recently we've started hearing that Medicaid and CHIP staff don't always understand what Title V does, or how the experience and expertise of Title V staff can be useful to them in serving their shared constituencies. Each Title V and Medicaid CHIP program is different depending on the state. These worksheets are customizable in order to address that and ready to be used as introductory or icebreaker materials on the importance of each program to children with special health care needs when relationships and communication pathways are beginning to be established. It's something you can bring when you're invited to the table to help introduce Title V in the context of Medicaid. It helps frame your case for why that partnership could be helpful and useful to the folks that you're working to connect with. Next slide, please. The Catalyst Center team has written several policy briefs and primers on topics relevant to Title V and Medicaid and CHIP partnerships. Here is just a sample of some recent ones, leveraging Title V partnerships to advance National Performance Measure 15, which is the Adequate Health Insurance for All Children measure, expanding access to Medicaid coverage through the Tefra option and children with disabilities. Next slide, please. A hot topic in the world of healthcare financing, as Karen noted, is value-based purchasing and value-based insurance design. The primer on value-based strategies for improving financing of care for children and youth with special health care needs was written for non-payer audiences to get familiar with the concepts and vocabulary associated with these strategies. There's a short list in this primer of suggested areas of focus that Title V and Medicaid and CHIP can partner around. I'd like to give a shout out now to Allison Martin of Oregon and Stacy Collins of AmCHIP, who helped serve as Title V reviewers for the primer. In May of this year, the Catalyst Center worked with the AAP on co-editing a special supplement to Pediatrics on value-based purchasing and value-based insurance design specific to children with special health care needs. It's available free to all readers and can be accessed through our website or that of Pediatrics. We were honored to have Jim Perrin write the introduction to the supplement. Next slide, please. I'd like to draw your attention to two supplement articles that I think have special resonance for Title V. The Statement of the Problem article offers not only examples of value-based purchasing and value-based insurance design strategies, but also an in-depth discussion of why it's important to focus on these topics and why there are unique opportunities and challenges in the value-driven financing of care for kids and youth with special health care needs. The Eye of the Beholder was written by a group of nationally recognized family leaders, and me bringing up the rear. It includes a discussion of quality and value from a family-centered and life course perspective, one that I think Title V staff are very well versed in and often help to share with payers and other stakeholders when partnering on any topic. Next slide, please. Here are some examples of resources focused on targeted populations, such as children involved in foster care who are all eligible for Medicaid, and in our estimation are all children with special health care needs. And another tutorial, this one focused on reducing inequities in coverage and financing. Next slide, please. Breaking the Link is about the financial hardship faced by many families raising children with special health care needs and includes data, policy analysis, and family stories, as well as strategies to help alleviate financial hardship. The care coordination conundrum tries to help answer that age-old question, how do we get care coordination paid for? Again, as Karen noted earlier, care coordination is a critical element of National Performance Measure number 11, medical home, and an organic place for Title V and Medicaid and CHIP to think about partnering, given their shared service populations, active role in providing care coordination, interest in reducing redundancies and eliminating gaps, and the financial constraints each program faces in providing care coordination to scale. We are currently working on a primer on the 2016 Medicaid managed care rules and their implications for children with special health care needs, so stay tuned for that. Next slide, please. As I mentioned earlier, in addition to these written resources, the Catalyst Center team is available to answer specific questions, help find data, interpret policy, and connect stakeholders interested in working together to improve financing of care for kids and youth with special health care needs. We look forward to hearing from you with your questions, your needs, and your feedback. I'll turn the floor back over now to Joanne with sincere thanks to you all for your time. Joanne?
Thank you very much, Meg. Before we move on to take audience questions, I want to bring your attention to numerous resources presented in the slide deck from our co-sponsors. Since the slide deck will be made available to all participants after the webinar, you will be able to review these resources in detail. So please take a moment just to take a look. And please forward any questions via the chat box to our team.
And hi, Joanne. This is staff from the National Center for Medical Home Implementation. We do have a couple of questions that have come in through the chat box. I'm just going to read them out loud here. I apologize. Our chat is having some issues. We did have someone ask a question to Colorado to see if the RCCOs are funded through Medicaid, and if not, who funds them?
Yeah, this is Susan. We do have federal matching funds that support the payments that we make to the RICOs, the RCCOs, and to the PCMPs. We make per member per month payments to each of those, to all of those groups, the 7 RICOs and all of the PCMPs. And then we also have incentive payments, which are federally matching dollars as well.
Great, and we had one other question come in for the Colorado team asking about privately insured children and youth with special health care needs and what kinds of plans and activities the Title V program has in terms of care coordination and other activities for that population. So once again, these are children and youth with special health care needs who are privately insured.
So this is Gina. Unfortunately, we don't have anybody from Title V on the phone with us, but I will get you an answer back and get it back over to NASHP so they can get you an email back with the information.
Great, and we have one other question to the presenters asking about how school administrators or school nurses can be involved in any work around medical home that's administered by Title V and Medicaid.
So we do have school-based health centers that serve as our primary care medical provider or medical homes, and they are, so long as they demonstrate that they meet the criteria of serving as a PCMP in the program, we are able to enroll them as a medical home, and then they receive that additional per member per month payment and are also eligible for any incentives.
Great. We have no further questions at this time, so Joanne, I'll turn it back over to you for closing remarks.
Thank you so much for your questions, and thank you again to our faculty. We appreciate your time and sharing your experiences and your expertise with us. This webinar recording, slides, and unanswered questions will be archived about a week from today on the National Center for Medical Home Implementation website. Additionally, you'll receive an email shortly after this webinar. We will ask you to complete an evaluation. It will only take a few minutes of your time. We value and appreciate your feedback. Thank you very much for your participation.